Every day you choose to move, your body responds with strength, balance, and renewed life. Each gentle motion is a gift to yourself, calm, mindful, and full of vitality. Together we move, we heal, and we thrive. Keep the rhythm of your golden years. Nurture health, cherish every movement. As global populations age, maintaining physical autonomy and a high quality of life in later years has emerged as a pressing problem for individuals, caregivers, and public health systems. For numerous decades, walking has been advocated as an essential element of good aging due to its cardiovascular advantages, widespread accessibility, and comparatively mild strain on the joints. This endorsement is still applicable. Walking effectively enhances aerobic fitness, aids in weight control, promotes regular physical activity, and fosters mental well-being through sunlight exposure and social interaction. A burgeoning corpus of research and clinical evidence suggests that walking alone frequently fails to mitigate two primary physiological threats to mobility in older adulthood: sarcopenia, the age-associated decline in muscle mass and strength, and a deterioration in neuromuscular coordination. Understanding the constraints of a solely walking-based regimen is crucial for developing a more holistic and pragmatic program that maintains functionality, mitigates fall risk, and fosters long-term independence. Sarcopenia is the gradual, widespread decline in skeletal muscle mass and strength associated with age. It generally commences insidiously in the fourth decade of life, and then accelerates with a significant rise after the age of 60. Peer-reviewed literature in gerontology and nutritional science indicates that several persons may have an annual decline of approximately 0.5% to 1% in muscle mass after midlife, with the reduction in strength often exceeding the decrease in bulk. The decline is most evident in the major muscle groups of the lower body. The quadriceps, gluteal complex, and calf muscles, specifically those muscles that facilitate walking, standing from a seated position, and ascending steps. The functional ramifications of muscle atrophy and weakness are significant: decreased gait, velocity, impaired postural stability, diminished capacity to execute activities of daily living, such as rising from a chair or ascending stairs, heightened exertion needed for routine tasks, and a markedly elevated risk of falls and associated injuries. Sarcopenia also leads to metabolic alterations, including diminished insulin sensitivity and modified energy expenditure, which can affect chronic disease susceptibility and general vitality. Walking is chiefly an aerobic exercise, primarily activating slow-twitch type I muscle fibers, which are optimized for prolonged endurance-based activities. These fibers facilitate prolonged low-intensity activities but offer minimal stimulation to the fast-twitch type II fibers, which generate rapid, forceful contractions and are essential for tasks necessitating strength, explosive movement, or swift corrective movements. Fast-twitch fibers are significantly impacted by age-related deterioration, and in the absence of specific resistance or overload training, they tend to atrophy more rapidly. Thus, depending solely on walking, even when conducted consistently, frequently does not deliver the incremental mechanical stimulus required to preserve or enhance muscle strength and neuromuscular response. These abilities are essential for prompt corrective measures, assured locomotion, secure stair traversal, and stability amongst environmental disturbances such as irregular pavement or an errant step. To reconcile endurance and power, exercise professionals, such as physical therapists and exercise physiologists, advocate for the incorporation of aerobic activities alongside particular targeted exercises that enhance strength, balance, and circulation. This comprehensive program emphasizes three fundamental evidence-based exercises: the wall sit, the standing calf raise, and the standing march. Each of these exercises is intentionally chosen to target the physiological deficiencies frequently linked to aging: weakness in the quadriceps and gluteal muscles, reduced calf pump efficacy, and compromised dynamic balance. They necessitate no specialist apparatus, can be executed safely within the home setting, and collectively constitute a pragmatic, efficient method for rehabilitating lower body strength, augmenting joint stability, and fostering long-term mobility. By comprehending the biomechanical principles and physiological advantages of each exercise, older persons and their caretakers can develop a balanced regimen that complements walking and diminishes dependence on endurance-focused activities. The wall sit, also referred to as the wall squat, is an isometric exercise wherein the muscles engage without significant joint movement. Despite its seemingly straightforward nature, the action possesses a significant ability to restore foundational, lower body power. The wall sit exerts sustained stress on the primary muscle groups responsible for body weight support and stabilization of the hip and knee joints, primarily the quadriceps femoris and the gluteal muscles, while simultaneously engaging core stabilizers to uphold spinal alignment. The quadriceps femoris, consisting of 4 muscles located on the anterior thigh, rectus femoris vastus, lateralis vastus medialis, and vastus intermedius, is the principal muscle responsible for knee extension. Robust quadriceps are crucial for standing from a seated position, climbing stairs, and managing descent. They also avert knee instability under weight. When maintained in an isometric position against a wall, these muscles experience sustained stress, a stimulus that fosters hypertrophy and neuromuscular adaptations, hence enhancing strength, power capacity, and fatigue resistance in ways that walking does not consistently achieve. The gluteus maximus and gluteus medius have complementary yet separate functions in movement and posture. The gluteus maximus serves as a potent hip extensor, facilitating propulsion and supporting upright posture, while the gluteus medius ensures pelvic stability during single-leg support stages of ambulation. Muscle weakness may manifest as an unsteady gait, diminished walking efficiency, compensatory lumbar lordosis, or a Trendelenburg-like presentation, potentially leading to lower back pain and lateral trunk lean. In a wall sit, the gluteal muscles are used to maintain the hip angle and prevent forward collapse, therefore enhancing their endurance and functional role in daily activities. The exercise requires the activation of core stabilizers muscles, like the transverse abdominis and obliques, which assist in preserving neutral pelvis and trunk posture during lower limb activity. An appropriately timed isometric hold trains not just isolated muscles, but also the coordinated interaction among lower limb and trunk musculature that facilitates safe, efficient movement. The wall sit's efficacy from a biomechanical standpoint stems from its isometric characteristics and the prolonged time under tension it creates. Prolonged contraction engages supplementary motor units and can augment neuromuscular activation, leading to changes that boost force production and fatigue endurance. Furthermore, while the feet maintain touch with the floor during the movement, the wall sit operates as a closed-chain exercise. Closed-chain exercises are generally beneficial for joints as they distribute stress across numerous segments and promote compressive stabilizing pressures at the knee and hip, rather than isolated shear forces that may exacerbate certain joint diseases. For elderly individuals with knee osteoarthritis or other degenerative conditions, meticulous consideration of alignment and depth enables the wall sit to be executed without aggravating symptoms while providing significant strength improvements. Isometric training has demonstrated efficacy in enhancing pain relief and functional capacity in certain groups with knee discomfort, provided it is prescribed correctly and participants adhere to proper alignment. To execute the wall, sit safely and efficiently. Commence by positioning your back flat against a solid, smooth wall. Position the feet approximately 18 to 24 inches from the wall, shoulder width apart, with the toes directed forward or slightly outward as deemed comfortable. Activate the core, gently retract the lower back toward the wall, and descend until the thighs are nearly parallel to the floor, forming an approximate 90-degree angle at the hips and knees, resembling the posture of an invisible chair. Ensure that the knees are aligned directly above the ankles and do not extend excessively beyond the toes to reduce anterior knee strain. Distribute weight evenly through the heels, maintain an elevated chest and relaxed shoulders, and breathe consistently during the hold. Breath retention can increase blood pressure and is unnecessary for the exercise's efficacy. To escape, apply pressure via the heels, engage the quadriceps and gluteal muscles, and ascend the wall with control. The possibilities for progression and regression render this exercise suitable for a diverse array of functional capabilities. Novices who consider a complete 90-degree hold excessively challenging may commence at a shallower angle, approximately 45 or 60 degrees, maintaining the position for 15 to 20 seconds and progressively extending both duration and depth as their ability enhances. A pragmatic strategy involves implementing time-based increments, increase the hold duration by 5 to 10 seconds every few sessions, or introduce an additional set whenever a single set easily surpasses the target hold time. An intermediate progression, once a 60 to 90-second hold at 90 degrees is feasible, may involve elevating the toes off the ground to redirect focus onto the heels and intensify activation of the posterior chain. Executing small controlled pulses by shifting an inch or two at the squat's nadir introduces a dynamic component, or grasping a lightweight household item such as a can of soup or a light bag to augment resistance. An advanced progression is a single-leg wall sit from the standard posture. Stretch one leg straight out in front, parallel to the floor, therefore increasing the load on the supporting leg and demanding balance. It is essential to execute the single-leg variation for a same period on both sides to maintain symmetry and mitigate the risk of unilateral imbalances. Frequent mistakes include let the knees to extend beyond the toes, curving the lower back away from the wall, or attempting a duration of hold that exceeds one's present capability, so jeopardizing form. Prioritizing proper alignment and contraction quality, favoring shorter, precise holds over longer, imprecise ones, will result in safer and more reliable progress. Individuals with knee or hip pain may benefit from minor modifications in foot positioning depth or employing a marginally elevated surface to minimize depth, so preserving advantages while preventing discomfort. Through consistent practice, numerous individuals observe significant enhancements in the strength and endurance required for daily tasks, such as standing from a seated position or ascending stairs. Results on timed functional assessments, such as chair stand tests, typically improve with regular lower limb strengthening exercises. The gastrocnemius and soleus muscles of the lower leg are essential for balance, propulsion, and circulatory function, although they are often neglected in home exercise routines. The standing calf raise is an uncomplicated, high-benefit exercise that focuses on these muscles and has advantages that surpass localized strength enhancement. The gastrocnemius is the superficial, visually noticeable muscle that extends over both the knee and ankle, playing a significant role in plantar flexion, the action utilized to propel off the ground during walking. The soleus is situated beneath the gastrocnemius and is especially engaged during standing and activities with a flexed knee. It serves as a potent postural muscle. Collectively, these muscles provide a musculovenous pump that is essential for the return of venous blood from the lower extremities to the heart. Their contraction compresses the surrounding deep veins, facilitating the upward movement of venous blood and aiding circulation against gravity. Consistent activation of the calf pump mitigates venous pooling, alleviates perceptions of leg heaviness, and may diminish edema in individuals with mild chronic venous insufficiency, especially when used in conjunction with additional interventions such as compression stockings and leg elevation when appropriate. As one ages and engages in more sedentary activities, the efficacy of the calf pump may diminish. The repercussions of diminished venous return encompass feelings of heaviness or fatigue in the legs, edema in the ankles and lower legs, an increased propensity for varicose veins, and in certain instances a heightened chance of venous thromboembolic events if additional risk factors are present. Regular activation of the calf muscles via controlled rises and lowers enhances venous return by consistently compressing and releasing the deep veins, hence promoting overall circulatory health and reducing edema. The calf muscles and the smaller intrinsic ankle stabilizers, peroneals, tibialis, posterior, and anterior, are crucial for balance and proprioception. Enhanced strength in these areas facilitates more agile responses to disturbances and uneven terrain, thereby decreasing the likelihood of sprains and falls. The calf complex also plays a role in ankle rigidity and propulsion strength during ambulation. Enhancing its functionality can moderately elevate walking velocity and diminish the energy expenditure of ambulation in elderly individuals. To execute the standing calf raise, maintain an upright posture with feet approximately shoulder width apart, positioned near a firm surface, such as a countertop, the rear of a robust chair, or a wall for minimal support if necessary. Assuming a neutral position, apply pressure via the balls of the feet and elevate the heels to the maximum height, emphasizing a deliberate non-bouncy motion. At the apex of the movement, pause for 1 to 2 seconds and consciously engage the calf muscles to optimize the circulatory and muscular benefits, then gradually descend the heels back to the starting position. The eccentric phase, characterized by controlled lowering, is equally crucial as the concentric phase for developing strength and tendon resilience. Target roughly 12 to 15 repetitions per set, with a rest period of 30 to 60 seconds between sets, and execute 2 to 3 sets based on tiredness and capability. Focus on symmetry, ensure both sides operate in unison, and refrain from disproportionately transferring weight to one side. Adjustments encompass a sitting alternative for persons with balance impairments or those for whom the standing variant is excessively taxing. The seated calf raise, executed in a seated position, with feet flat on the floor while elevating the heels, targets the soleus muscle and serves as an effective introductory exercise, particularly for deconditioned persons or those with restricted standing endurance. Advancements from the standing variation encompass extending the peak hold duration to 3 to 5 seconds to enhance time under tension and test muscular endurance, executing single-leg calf raises to amplify the effective load on the working limb and further engage ankle stabilizers, or ascending onto a stair or low platform to augment range of motion and target the muscle tendon unit through extended excursion. When executing single-leg variations or ascending an elevated level, utilize a railing or firm support for equilibrium and maintain controlled movement to mitigate the danger to the Achilles tendon. Safety issues highlight the importance of preventing momentum as it diminishes effectiveness and may impose excessive strain on the Achilles tendon. Keep a slight flex in the knees instead of locking them and traverse the complete range of motion that is comfortable. When ascending an elevated surface to improve range of motion, ensure stable footing and utilize suitable rail or hand support. Individuals with recent ankle sprains, Achilles tendinopathy, or significant peripheral artery disease should seek medical advice prior to augmenting calf loading activities. The standing march is a crucial exercise for dynamic balance, hip flexor strength, and neuromuscular coordination. Static strength establishes a fundamental foundation, although the ability to maintain balance during movement, dynamic stability, is crucial for successfully navigating the sometimes unpredictable conditions of daily life. Walking entails recurrent brief instances of single-leg stance. With advancing age, the capacity to maintain balance on one leg may deteriorate due to a confluence of muscular weakness, diminished neuronal response, times decreased sensory feedback from joints and plantar surfaces, and compromised vestibular function. The standing march intentionally isolates and retrains the single-leg support phase in a purposeful, controlled manner, enhancing the muscular and neurological coordination necessary for maintaining balance throughout movement. The principal muscles engaged in marching are the hip flexors, particularly the iliopsoas, which elevate the thigh towards the torso and are crucial for foot clearance during locomotion. These muscles may weaken or shorten in individuals who remain sitting for extended durations. The standing march fortifies the hip flexors and mitigates habitual tightness by actively elevating the knee. Simultaneously, the gluteus medius of the supporting leg functions to stabilize the pelvis, preventing the opposite hip from descending, a phenomenon indicative of a Trendelenburg gait, which denotes hip abductor deficiency. The core muscles must engage to sustain trunk stability and avert compensatory tilting. The standing march cultivates a cohesive pattern of muscle engagement and sensory feedback that is directly applicable to safer, more assured ambulation. The exercise enhances the proprioceptive loop, which is the ongoing feedback from muscles and joints to the neural system that facilitates spatial orientation and movement planning. Every deliberate, gradual knee lift tests balance receptors and necessitates the nervous system to execute minor ongoing modifications to muscle activation patterns. Through continual practice, these micro-adjustments enhance efficiency, consequently augmenting reaction speed and the capacity to adapt to slips or accidents. The standing march serves as both a strength exercise and a specialized neuromotor retraining method that enhances sensory integration across visual, vestibular, and somatosensory systems. To execute the standing march, maintain an upright posture with feet positioned hip-width apart. Use a supportive platform if necessary. Uphold an upright stance with the chest elevated, shoulders at ease, and eyes directed forward. Transfer weight onto one leg and gradually elevate the opposing knee towards the chest, targeting a thigh position that is about parallel to the floor or at a height that is comfortable and manageable. Pause for 1 full second at the apex of the lift, sensing the stabilizers of the standing leg and the core engaging to sustain balance, then gradually drop the elevated foot back to the ground. Alternate legs in a fluid, rhythmic manner for a duration of 30 to 60 seconds to complete one set. Advancing the exercise may entail diminishing dependence on hand support, transitioning from bilateral to unilateral support, then to fingertip support, and ultimately achieving independent balance. Elevating the knees higher, extending the duration of the hold at the apex of the lift to 1 or 2 seconds, or incorporating contralateral arm movements to replicate natural gait patterns. Light ankle weights, such as 1 to 3 pounds, or hand weights, can provide a slight resistance for skilled practitioners. However, they are often unnecessary for most users. Frequent mistakes in the standing march are permitting the torso to bend or rotate to aid the knee lift, relying on momentum instead of hip flexor power, and directing the gaze downward, which undermines balance. Maintaining a forward focus enhances stability. The movement must be intentional and regulated, emphasizing the quality of the pattern more than velocity. Incorporating occasional dual-task challenges, such as counting backward, holding a light object, or executing modest head turns, is beneficial as real-life balancing requirements frequently arise when attention is divided. Progressive dual-task training conducted under physician supervision can enhance fall-resilient balance. Significantly, these 3 exercises, the wall sit, the standing calf raise, and the standing march, are intended to enhance rather than substitute for walking. A synergistic method that preserves aerobic fitness while targeting strength, ankle circulation, and balance yields a more robust and versatile lower body. Integrating the exercises into a brief daily regimen is pragmatic and time-efficient. A full session encompassing warm-up and cool-down typically necessitates under 10 minutes and can be seamlessly incorporated into existing standing activities, such as during commercial breaks while brushing teeth or immediately following a short walk. Given that adherence frequently constitutes the primary predictor of benefit, the little time investment and the capacity to perform these exercises without specialized equipment enhance the probability of constant practice. A proposed framework for a weekly regimen underscores consistency and incremental intensity while facilitating recovery. Commence each session with a succinct 2 to 3 minute warm-up, marching in place mild leg swings, ankle rotations, or leisurely walking to enhance blood circulation and joint lubrication. The primary regimen may consist of 2 to 3 sets of wall sits, maintained for 20 to 60 seconds based on current capability, 2 to 3 sets of 12 to 15 standing calf raises, and 1 to 2 sets of standing marching for 30 to 60 seconds. A pragmatic weekly regimen involves executing the routine 5 to 6 days weekly as a brief daily exercise or 3 to 4 times weekly, supplemented by walking on alternate days, both of which can be efficacious based on individual schedule and recovery requirements. Conclude each session with 2 to 3 minutes of moderate stretching targeting the quadriceps, calves, hip flexors, and lower back to enhance flexibility and reduce post-exercise stiffness. Over the course of several weeks, progressively augment hold durations, repetitions, or the difficulty of progressions in accordance with enhanced strength and balance, incremental adjustments. For instance, extending wall sit holds by 5 to 10 seconds, increasing calf raises by 2 to 3 repetitions, or adding 5 seconds to marching sets, bi-weekly mitigate the risk of overuse injuries while promoting adaptation. Tracking progress sustains motivation and guarantees that the program produces significant change. Inexpensive and straightforward functional assessments can be conducted monthly. Gait speed over a brief distance, such as a 4-meter or 10-meter walk, serves as a robust predictor of mobility and health outcomes, generally enhancing with increases in strength and control. The 30-second chair stand test, which counts the number of times an individual can rise from a chair in 30 seconds, is responsive to variations in lower limb strength. Single leg stance duration evaluates balance asymmetry and stability. Monitoring these parameters in conjunction with subjective assessments like perceived exertion and confidence in ambulation and stair navigation offers valuable insights for modifying intensity and development. Optimizing the advantages of this exercise paradigm relies on a focus on comprehensive health behaviors. Sufficient dietary protein facilitates muscle repair and synthesis, with many experts advising older adults to target approximately 1.0 to 1.2 grams of protein per kilogram of body weight daily to mitigate sarcopenia. Protein requirements may increase for individuals experiencing acute illness recovery demands or engaging in more rigorous resistance training. Distributing protein consumption throughout meals and using a high-quality protein source post-exercise can optimize muscle protein synthesis. Hydration, adequate sleep, and the management of chronic illnesses, including diabetes, peripheral neuropathy, cardiovascular disease, arthritis, and Parkinsonism, affect exercise tolerance and recovery. Thus, they should be optimized alongside physical activity. Vitamin D levels influencing muscular function and fall risk provide another modifiable aspect to address with a healthcare professional. Prior to commencing any new exercise program, especially for individuals with substantial or multiple comorbidities such as osteoporosis, with vertebral fragility, symptomatic arthritis, uncontrolled hypertension, unstable angina, recognized significant cardiac arrhythmias, or a recent history of falls, consultation with a physician or a licensed physical therapist is advisable. These specialists can customize exercises to particular abilities, suggest suitable progressions, and recognize contraindications or essential safeguards. Pragmatic factors facilitate compliance and safety. Select a stable surface and suitable footwear that provides adequate grip and support. Verify that the exercise area is devoid of loose rugs, clutter, and other tripping hazards. Utilize a stable chair, countertop, or wall for balance when required. And heed the body's signals, adjusting or ceasing movements that elicit sharp or atypical pain. A caregiver or family member might serve as a spotter for individuals with balance difficulties until they gain confidence. In communal living environments or outpatient clinics, supervised group sessions conducted by a qualified practitioner can offer social support guidance and expedited skill acquisition compared to unsupervised practice. Basic instructions such as maintain an upright posture, inhale deeply, align knees with ankles, and proceed with caution and intention can uphold proper technique and diminish the risk of harm. Customizing the program for specific populations guarantees inclusion. Individuals with restricted mobility or those utilizing assistive devices, cane walker may benefit from adaptations such as executing wall sits at an elevated hip angle, seated marching raising one foot slightly off the ground while seated, or seated calf raises with a resistance band or light weight positioned across the knees. Individuals with peripheral neuropathy should prioritize balance support development, potentially first with seated exercises and gradually increasing standing tolerance. Individuals with osteoporosis should refrain from fast spinal flexion and high compressive axial loading. Nonetheless, isometric lower limb training and meticulously monitored progressions can enhance muscle function and balance without excessive risk. Behavioral techniques improve sustained compliance. Establishing the routine in conjunction with an existing daily habit, such as post-morning teeth brushing pre-lunch or during a specific television program utilizing reminders, alarms, mobile applications, fostering social accountability, exercising with a friend or family member, setting small, quantifiable objectives, and acknowledging incremental progress all enhance the probability of the program becoming habitual. Self-efficacy develops through successive achievements. Initiating with attainable objectives and progressively escalating challenges enhances confidence and diminishes attrition. Common clinical inquiries and troubleshooting. If an individual has knee discomfort during wall sits, decrease the depth to maintain a knee angle exceeding 90 degrees, assess foot positioning and knee alignment, and guarantee a progressive progression. If calf raises induce Achilles discomfort, limit the range of motion and focus on a steady, controlled, eccentric descent. Consider initiating with sitting variations to enhance soleus strength prior to progression. Should the standing march induce dizziness, cease the activity, ensure proper hydration and recent nourishment and practice while utilizing a support. If dizziness continues, obtain a medical assessment for orthostatic hypotension or vestibular impairment. Combining these workouts with additional therapies can enhance effects. Resistance bands, ankle weights, or domestic items can incrementally enhance resistance when suitable. Incorporating upper body strengthening trunk rotation and spinal extension movements enhances lower body training and promotes total functionality. Integrating balance-challenging surfaces such as cushions or foam pads under expert supervision can augment proprioceptive improvements. For individuals recuperating from acute hospitalization or surgery, a systematic progression and cooperation with rehabilitation specialists are essential to harmonize tissue healing with functional recovery. Examples demonstrate the adaptation of the curriculum across varying aptitude levels. An unconditioned older adult may commence with a seated warm-up, execute a 30-degree wall lean for 15-20 seconds twice, complete 2 sets of seated calf raises for 12-15 repetitions, and engage in seated marching alternately lifting heels and toes for 30 seconds, advancing over 8 to 12 weeks to standing variations. An individual with moderate activity levels may execute 2 to 3 sets of 40-60-second wall sits, 3 sets of 15 standing calf lifts, incorporating a single leg variation for advancement, and standing march sets lasting 45 to 60 seconds with diminished hand support. An advanced individual proficient in balance and strength may execute single-leg wall sits for 20 to 30 seconds each leg, single-leg calf raises on a step for 12-15 repetitions per side, and standing march with elevated knee lifts and dual-task components. Evidence-based indicators of success encompass enhanced gait velocity. Typically, an increase of 0.1 ms or greater is deemed clinically significant. Elevated scores on the 30-second chair stand assessment, prolonged single-leg stance durations, diminished self-reported anxiety regarding falls, and augmented autonomy in instrumental activities of daily living. Even slight enhancements in these metrics correlate with significant increases in autonomy, decreased healthcare utilization, and improved quality of life. In conclusion, although walking is a vital and beneficial activity for older persons, it does not fully address the multifaceted decreases in muscle mass strength and neuromuscular control associated with aging. The wall sit enhances quadriceps and gluteal endurance, fortifying the muscles necessary for standing from a chair and stabilizing the knee and hip. The standing calf raise enhances the musculovenous pump, facilitating venous return and ankle stability, while strengthening the muscles essential for push-off during ambulation. The standing march enhances dynamic balance and hip flexor strength, improving neural control and single-leg stability, which directly contribute to safer and more certain walking. When executed collectively, these 3 accessible, no-equipment workouts constitute a pragmatic, time-efficient home regimen that targets the fundamental mechanical and neurological factors influencing mobility in later life. The aim of a meticulously crafted fitness regimen for older persons is not just to maintain ambulation, but to facilitate mobility with enhanced purpose, cognition, and power. By integrating aerobic exercise with specific strength and balance training, adults over 60 can proactively adopt evidence-based measures to preserve independence and enhance quality of life. Advancement transpires incrementally, and significant enhancements can be realized by each intentional, meticulously conducted action. By prioritizing safety, nutrition, and regular practice, this simple fitness regimen can significantly enhance functionality, diminish fall risk, and facilitate enjoyable, independent activities that enrich later life. Every day you choose to move, your body responds with strength, balance, and renewed life. Each gentle motion is a gift to yourself, calm, mindful, and full of vitality. Together we move, we heal, and we thrive. Keep the rhythm of your golden years. Nurture health, cherish every movement.